We are so delighted you're here twice now in 2 weeks, and it's an absolute joy to work with Sandra, and I'm so glad she can share this with all of you broadly. So Sandra Fortes, come on down. Thank you so much. Thank you.
Okay. Can you hear me? Yeah. Good. First of all, it's a great honor to be here and to speak to the faculty, the students, and the people, other colleagues from the College of Public Health and Health Policy. And I'm very grateful that I could stay, but thank you also for the nice storm last week, for a Brazilian. Yeah, I will never forget it. For a Brazilian, I have to admit that was the greatest amount of snow I ever saw in my whole life in one day. So, and I would, of course, would like to thank Dean L. Mohandes, especially for the invitation, and also the faculty and staff, but not only from here, but from the Center for Innovation of Mental Health, and my dear friends, Sean and Jennifer, for the partnership, not only for inviting me here, but for the work we have been doing since 1 year now. Yeah, it began in Carnival in Rio, and it went through a snowstorm in Brazil, you know. No, it was not during Carnival, it was just after. It started in the last day of Carnival. And thank you so much also for Paulo Leslie for all his logistical support. Okay, so I'm going to talk about primary mental health care in Brazil. And so let me see. Here? Yeah. Great. First of all, I would like to discuss with you what are the bases of our conception of primary mental health care in Brazil. What are our principles? What do we follow? The type of understanding we have for primary mental health care in Brazil. So in 2007, Lancet had a special number on primary mental health that launched this slogan, no health without mental health. And so that's the most important aspect of it. Of course, everybody knows that mental health disorders are highly prevalent. They are one of the leading causes of DAILYs. But the sad part of it is that between 33% to 77% of people with mental disorders do not receive treatment, especially in Islamic countries like Brazil. Brazil is considered now a middle-income country. And the annual expenditures on mental health may be as small as $0.25 a year per person in low-income countries. And mostly, we still have most of it allocated in psychiatric hospitals. Brazil is not that different, although it's different in some aspects. 20% of our population, general population, have significant level of emotional distress, especially common mental disorders. In the waiting room of a primary care facility, 50 to 60% of the people waiting for any type of consultations will have significant level of emotional distress. 40% of them will fulfill criteria for anxious or depression syndromes. So 40% of the people waiting for any type of consultation in a primary care unit will have mental health problems. And they represented in 2007 around 1/4 of DAILYs in Brazil. So the mental health gap is a problem. Mental disorders are highly prevalent and not adequately treated. What are the problems that are connected to mental health gap? First of all, lack of access. And I do not mean specifically financial difficulties of access, as we're going to see it pretty soon. The Brazilian health system is universal and free. But the people come to the consultations, but detection level is low, very, very low. And also, keeping a continuous bond with the professional and guaranteeing the treatment for disorders that are chronic by definitions, mental disorders are chronic disorders, is very difficult to guarantee, especially because the training of the primary care providers is inadequate when it comes to mental health. Also, another problem is that mental disorders are strongly associated with social determinants, poverty, lack of education, violence, and with stigma. So all primary care providers several times have difficulty in dealing with the mental emotional suffering and emotional distress these people present because the way they are connected to social problems and personal problems. But inadequacies in the mental health system and in the general health system are also associated with this problem. Medication is not available. We have a lack of psychosocial interventions and a lack of intersectorial support interventions. So, to this huge problem of the mental health gap of treatment of mental disorders that are so prevalent, the first question is primary mental health care a solution? For us in Brazil and for WHO also, it is. It can be considered a solution. 70% of the people with emotional distress are already in primary care. They don't have to go there. They are already there, sitting. As I said, 50% of those people in waiting rooms. But the primary care providers are not aware that they are there and that something can be done at that level. In reality, if we consider one of the references that we have in Brazil on primary care, which is, of course, Barbara Starfield, she has been very important in the organization of the primary care system in Brazil. Now, primary care should solve 80% of health problems, and that must include mental health. No health without mental health. So, the first point is, it starts shifting, but more than that is, we don't need specialists only to take care of mental health. Primary care professionals, together with mental health workers, should work together to determine an integrated care that would bring better outcomes for these patients. So, 3 questions. This comes from a paper from Vikram Patel, which is one of the most important authors in the area. Now, why integrate mental health care in primary care? What to integrate and how to integrate? Why integrate? First of all, mental health is much more than mental disorders. We have to remember that. We are not speaking only on mental disorders. We are speaking on mental health. And when we come to speak on mental health, we also speak about the problems of emotional distress associated with other disorders such as tuberculosis, hypertension, diabetes, medically unexplained symptoms that are brought to primary care, usually, no? So, and also mental health is associated with social problems and violence. So we cannot separate. Why integrate? Because it is already integrated. And primary care is the closest level of treatment to the people, to the communities, the families, and the individuals. So, what should we integrate? First of all, we should be able to draw a model of taking care of people that would be integrated in the sense that it has to be biopsychosocial. We cannot separate it. We cannot separate these different parts. And also, mental health, especially because of the problem of stigma, it should be delivered where people live, where they go to get treatment for other things. So, not necessarily, I am going to the psychiatrist, so I have a psychiatric problem, so I am somebody different. I'm just going to my GP or my family doctor. He will take care of my diabetes, my tuberculosis, my depression. So, we overcome stigma when we do primary mental health care. Besides that, primary mental health care is interdisciplinary and intersectorial work. We need social workers, we need psychologists, we need doctors, nurses. So these type of things can be found in primary care. And primary care is also, and once again, Barbara comes here, is also responsible for coordination of care. So as primary care coordinates care, it also guarantees a longitudinal approach of care that is important for mental health. So how can we integrate? First of all, what came out, and there are several models with proven effectiveness all over the world through integrated process, work process, which are called usually collaborative care. So different work process is not the same thing that is done in specialized versus primary units. It's an integrated system that needs to amplify and improve care, but we have to train professionals to work in this new model, because we have been trained. I mean, when I went to university and residence, I was trained totally separated from other areas. Specialists, especially in mental health care, were very, very much isolated. So, based on this principle, how is the situation in Rio and in Brazil? What's the scenario? Well, in 1988, when dictatorship ended in Brazil and we had a new constitution, health was considered a right to the people, a right of the people, and a duty of the state. And that led to the creation of the SUS, Sistema Único de Saúde, which is the national unique system, which is one public-funded universal health system that covers 20 million people of a quite complex country. We have the Amazon and São Paulo. We have large areas of forests that it takes you, counties that takes you like 6 hours in a boat, 12 in a quick boat. If it's a slow boat, it takes 12 hours, but also we have São Paulo with 20 million people. And this system is county-based because we consider that it was necessary, that it was next to the people. And we have 5,570 counties. So we have this national system, which is universal and free, but it's allowed also to have private insurance system, which is private, and only 1/3 of the population have. But the fact that you have a private insurance system, you still have the right to go to the national health system, which includes, it is really universal. It includes everybody who is here in this room if you were in Rio. So if you have nothing's going to happen to Sean when he goes there, but anyway, if he had an accident, he would be taken to the national health system, emergency system, and no charge at all. No? And so this change included a change in the primary care system. In the old system, the primary care units were units with no geographical reference. One unit would be the only unit for like 170. In my area, each unit would have 170,000 patients that would be attended by demand. What means if you did not go to the unit, nobody would ever know that you existed. And in this unit, you will have doctors like pediatricians, gynecologists, internal medicine, because by then we did not have family doctors. We would call them GPs because we did not have family doctors. No? And the person she would go for a consultation, but she would only be included for follow-up if she participated, or she could be included in one of the public health programs, which were children and women's health, chronic disease such as hypertension and diabetes, tuberculosis, and Hansen, which unfortunately we still have. Mental health was not a priority, and it was centered in psychiatric traditional hospitals. But then in 1994, the family health strategy, then called a program because it was the beginning, was created. Now it is a strategy. Now we have 40,000 teams that cover about 140 million people directly covered by the system. Each team is based on a territory. So it's geographically, the team has a geographically assigned area. This area, usually you have between 3,600 to 4,000 people. And these teams, and this was something that took us some time for Sean and Jennifer to understand, the basic system is not a unit, is a team. So each team take care of 3.5 thousand to 4,000 people, and each team has a doctor, ideally a family doctor, still only 20%, 15 to 20%, a nurse technician, and 6 community workers. And these teams are responsible for everything: health promotion, health prevention, diagnosis, treatment, rehabilitation, including intersectorial area work such as the Bolsa Familia. They participate in the Bolsa Familia, which is the biggest social program, and also in disease surveillance actions. So all their surveillance actions related to Zika, to dengue, to all these epidemics are based on the family health teams. So this is a drawing, no? And we have here, I think I can use that, yes. So in these units, for instance, we have 7 teams. So this unit would be 4 times 7, it would be around 30,000 people. Each team, a doctor and a nurse and 6 community workers. And these community workers have their areas, each with about 150 families. These community workers, they provide comprehensive care. No, they follow up for immunization. They guarantee breastfeeding. They go after people that have chronic disease. They may make clinical triage. No? And they are part of the team. And working with this team, we have an auxiliary team where the specialists are. And this auxiliary team is called matrix support teams. That's where the mental health professionals are. So you may have psychiatry, most of them have physiotherapists and psychologists, but you can have other medical specialties such as pediatricians, gynecologists, and so on. And so this is how the system works, okay? So the mental health care to be provided by these teams with the support of the matrix support teams, it means integration between specialized and primary care teams, not only by referral, but real integration. The objective is that primary care teams will solve most of the mental, or help people with most of the people with mental health problems. Of this model of collaborative care, it is not native to Brazil, although the name matrix support is Brazilian, but you have the shared care model in Canada, and you have the collaborative care in USA that started and has been very well developed by the University of Washington with Caton and Nugent in Seattle. No? So the aim is not to increase detection and referral, it's to increase detection and treat it in primary care, solve it in primary care. So as we have already said, primary care providers do not know that much about mental health care because training in undergraduate medical school is mostly focused on very, very severe cases. Now, these specialists help these teams to develop these skills and also to develop new types of intervention. So in 2001, the first experiences started, and in January 2008, this system was officialized with the NASF. NASF is Núcleo de Apoio à Saúde da Família in Portuguese, which are the family health support teams. We call them matrix support teams. In 2009, we had almost 2,000, now more or less 3,000, and we should have 4,000, which is one matrix team for each 10 teams. We have 40,000 teams. Most of them have psychologists, about 25% of them have psychiatrists, but also social workers and occupational therapists. No? So this is the drawing of the system. You have one in one unit, And in the matrix support, you will have the mental health support, the women's health support, the child health support team. And they work together. That's why it's called a matrix. It makes a matrix. No? So what are the principles of this work? First of all, exchange knowledge between specialized mental health professionals and primary care providers from the family health teams. That aims to strengthen patient-centered medicine and guarantees continuing education. How does it guarantee? It guarantees through case discussion, interdisciplinary action, and the most effective ones are joint consultation and joint home visits. Because these teams, they do a lot of home visits because they are connected to a specific assigned area. So, and this is a very important point. If the patient doesn't go to the unit, the team goes to the patient. It's very different from traditional care. No? And so, but it also includes mental health promotion, preventive actions, and of course, developing therapeutic projects for patients, families, and communities. No? So, this has mental health actions in matrix support have allowed us to offer better care for families under vulnerable conditions, support the family health teams, help the family health teams organize an integrated mental health network with primary, secondary, and tertiary units. Remember, primary care must coordinate the system, but the mental health specialists help. And develop new mental health therapeutics interventions. In Brazil, several of these interventions have been group interventions, but we are a collective social society. We're going to go back to that. It's a different pattern. For us, that's very useful. It doesn't mean it's going to be useful everywhere, but for us, it works. And building this community-based mental health involved working with another big change in the Brazilian health system after the Constitution, which are the CAPs, the Community Psychosocial Centers, which are our community mental health centers, that allowed most of the traditional psychiatric beds in Brazil to be closed. So this was a great advance. Now we have more than 3,000. In 2009, we had about 1,500. They have reintegrations programs. We have reintegrations programs for people that have lived several years in psychiatric hospitals with new therapeutic residents. But these units must also work with primary care, because the primary care professionals are those that know where the most severe patients are, because they are those that know that community. So if we go back to mental health problems in primary care, we can divide them in two great groups. First of all, the most prevalent but less severe cases. And second, the very severe cases. Primary care must organize care for the severe cases, but must provide care for the most prevalent cases, just like they do with hypertension and cardiovascular problems. So, which are the problems that we expect them to solve? Of course, anxious and depressive disorders, alcohol problems, and that's what the project, Sean's project and Jennifer projects come in now with us. Children with learning disability, and also emotional distress due to violence and unfavorable conditions. How can we evaluate? And then we have been participating in several of these projects. We now, in our research laboratory in the State University of Rio, we have 15 years in our research line on that since 2002, and several different types of projects, and including training projects. But now we are very much interested in evaluate if matrix support does work. How could we evaluate it? First of all, access. It has to provide access. Second, it should prove to be effective, feasible, and acceptable. It has to be of good quality, and it has to guarantee longitudinality. It's a difficult word to say, even in Portuguese. No? And so Longitudinalidade, exactly. And so we did a study that we are trying to publish. We have submitted already. And we compared care provided for common mental disorders, patients with anxiety and depression, in a traditional unit and in the family health strategy unit in 2011 till 2013. It is at that time, both units existed in one same area. This area was a big slum in the university area. Rio is divided in 10 areas because it's 10,000 people. And this area is one of the most violent areas. It's known worldwide because it's the community where the narco-trafficking dealers shot an helicopter. I don't know if any of you have heard of that, but they shot it and they put it down, And so we had by then the two units, the two types together. And so we went there. We had 5 doctors in the traditional unit, and we had 3 teams in the family health strategy teams. Look, this was real-life study, no randomized control study. During that year, one team in the family health strategy stayed 3 months without a doctor. The other team for 2 months stayed without a nurse. For 3 months, they did not receive payment. Real life, the way it is. But they had matrix support. Once a month, a psychologist came for 5 hours to work with the nurse and the psychiatrist to work with the doctor. So we screened patients in the waiting room, detected 150 patients in each unit, and with the HAD, the Hospital Anxiety and Depression Scale. They were positive for either anxiety, depression, or both, and we gave the professionals a list of those patients, and we went away, and we came back 1 year later and went for the records. Well, in the traditional unit, only 94.4% of the patients were detected and treated, mainly with benzodiazepines, which is one of the worst problems in mental health care in Brazil, which is the inadequate use of benzodiazepines. In the family health strategy teams, with the matrix support, detection increased to 24.3%. They changed totally the spectrum of medication used. It was mostly antidepressant. And although it was still, in average, for 3 months, not 6 as would be recommended, it was much better than what used to be. I know this table is a lot of crowded, but I just want to show you something. You see, in both systems, the traditional one and the family health team one, the care was provided mainly by nurses and the doctors, not by mental health specialists. But with the matrix support, we increased the contact of the patients with the specialists, because the specialists went for joint consultations. The doctor found out, or they suspected that there was something going on, and they said to the patient, I'm going to arrange the next meeting with you, with a psychiatrist or with a psychologist. Is that okay for you? Well, people said sometimes people are scared that the patients would feel too many professionals. Guess what? They feel very well because they think they are being submitted to I don't know how you call it, junta médica, a medical board. And so they're very important because all these specialists are coming to see them. And so that increased, and reference did not increase, decreased a little when we compare it to the level of detection. But in the total, in the traditional unit, only about 2% of the patients will get to go and see a psychologist. With the new system, 7% went. In the old system, 1.3 patients, with all of them with anxiety and depression, would go and see a psychiatrist. In the new system, that reached up to 8%. So even being treated in primary care, matrix support, increased contact with mental health specialists. Of course, it increased detection, it qualified the use of medication, it reduced referral, but we did not notice an impact in psychosocial interventions. And that's now one of our main aims or main objectives of research. That's what both Jennifer and Shen, we are studying together on that. WHO, in the mental health gap intervention guide, has defined it very clearly that psychosocial support interventions should come for mental health care since the beginning. It doesn't matter if the patient is getting or not medication. Medication can only enter at a certain level, but psychosocial support interventions should always be present. But there is a necessity that we develop interventions in primary care. You know, I have here my friend Annika from Colombia, that she's also in a project in Brazil, studying interpersonal therapy as one of these interventions, as Jen and Shan are doing, because these interventions enhance social support in poor neighborhoods, which enhance self-esteem and empowerment, which they must include psychoeducation and address stigma, but they increase quality of life. In Brazil, as I have said, groups work very well, but we are a society with a strong collective perspective. Maybe it won't work everywhere, but in Brazil, it works. So we have one intervention called community therapy. Now, here's a group at the waiting room discussing diabetes and hypertension. We have developed an intervention of support and organization of handcraft groups for women, because women, most of the patients with anxiety and depression are women, as I think everywhere. And so these craft groups offer safe support, support groups for the development of self-esteem and empowerment. The definitions they have is, this is a space for myself. That's what the women say. They promote inclusive interventions together with NGOs and also income-generating activities. But look, 5,570 counties. We have as many alternatives being developed by people that are there treating people. So one of my favorites are art groups for children with the psychologists and the community workers for children that have witnessed violent actions in the community they live. And they have had behavior change. And so these interventions promote that they can draw and discuss and talk about it, and they improve. Another one, of course, is the group support for common mental disorders, which includes psychoeducation and the enhancement of adequate use of psychotropic medication, because that's a huge problem in Brazil. We have to do something, otherwise the easiest thing would be to put benzodiazepines in the water supplies, because the amount of people using benzodiazepines is so in an unbelievable high. But other professionals from the matrix teams, like the psychotherapists or the physical education, they also are very much willing to develop interventions for mental health care. So physical activity. Everybody knows that when we go to the gym, we'll feel better, mentally, emotionally, relaxation activities. Mindfulness meditation. We now have a project called Medita SUS. We are getting the SUS to meditate. We think that in this difficult moment Brazil is going through, we need the people to meditate. Another alternative practice. And so that's why we strongly believe, and we promote private mental health care. But because it is, in our perspective, a solution for the mental health care. But for it all to happen, mental health care has to become a priority. It needs to be understood as part of primary care. It needs to be understood as part of a biopsychosocial model of care. It has to be supported, especially financially. It has to be interdisciplinary. It has to be part of an integrated health system, and it must be culturally competent. So I have here some references, and thank you very much for your attention.
Thank you, Sandra. We have an opportunity for some questions, and I think we have some microphones as well. What questions do you have? Sure, Dean Almohandes.
I think integrating mental health services into primary care is a conversation that has been occurring in the United States now for approximately 20 years. The definition, the classification of psychiatric services as the spectrum of primary healthcare services, including pediatricians, internal medicine, and OBGYN, was a revolutionary step towards reimbursement. But the issue of reimbursement for mental health services, you survive in a single payer system. And the major obstacles we face in the United States is not because we're not convinced that mental health belongs to the primary health care umbrella of services, but we have faced actually a lot of pushback from the American Psychiatric Association in the United States because of issues related to reimbursement for services and prescribing psychotropic drugs. And there are many community-based interventions that attempted to utilize behavioral approaches alone and failed in the United States, including interventions during pregnancy, randomized clinical trials for 1,500 women, etc., etc., that it does not seem that these behavioral interventions alone are able to really show results that are encouraging. So we are faced with that obstacle, which is, obviously behavioral therapy with pharmacological interventions are very effective. Who is allowed to prescribe psychotropic drugs, and who monitors the effects of psychotropic drugs over time? And how do you measure success? I mean, if yes, that's great. So 23.5% have been identified in the clinic. But then how are you identifying success in management? And that ends up being usually the area where we find a lot of pushback, that really some of these community-wide interventions are not that successful. So I'm going to push back just a little.
Okay, good. First of all, we have to understand that we are working in a different context. So instead of we have problems of money, the matrix support teams in the national health system has provided thousands of new jobs. So if we have in Brazil nowadays around 6,000 psychiatrists, and several years ago I'm a member of the National Brazilian Psychiatric Association. More than 15 years ago, I was in a meeting, and we discussed it like, we will need about 4,000 places, psychiatrists. We would have 4,000 places for psychiatrists working in this system. There are not enough psychiatrists to go. So one of the best medical specializations in Brazil now is psychiatry, because there is this large market. And there are no problems of financial problems, because everybody just works for the national health system. No? Second, the Brazilian law is such that when you graduate a doctor, you don't need to have a specialization for anything. You are a doctor. So you can prescribe psychotropic medication. No problem with that. When the psychiatrists complain, we go like that. Let's make a little... I'm an epidemiologist. I was talking to Luis today. My PhD was in epidemiology, so I like to deal with numbers. I love numbers. They're very concrete and very secure. So one team takes care of 5,000 people, or 3,000 people. 2/3 of these are adults. We have we have around 15% of those with anxiety and depression. So that gives us 300 people. We have 10% with alcohol problems. So that's 200 people. And then we have 3% with severe mental disorders, 3 to 5%. That's 150 people. So each team, we calculate more or less that each team have around 500 people with mental disorders. And we have 40,000 people, 40,000 teams. So we have each team with 500 people. So when the people start, when the specialists start saying something about you are getting our patients, our answer is, I'm sorry, we have enough patients for everybody, and we'll still need more providers. No? And so the people sort of do not create the same amount of problem you have, because first of all, we guarantee jobs, we are not doing anything illegal, and it's impossible to take care only from a mental health perspective. But there was another point, sorry, that you asked.
Whether you show
Yeah.
the efficacy of
Yeah.
behavioral interventions
Good.
that are not backed up.
Yes.
Have you shown?
Yeah. The point with behavioral interventions is everybody knows that they are enough for mild to moderate, but once you have moderate to severe disorders with functional, very high level of functional disabilities, then you have to get in with medication. So what we are doing now is the first thing we are evaluating is access. Because if you don't have access, nothing else works. And the matrix support teams that we have now, some of the teams, in the last 2 years of the last government in Rio, they did an evaluation which would consider how many patients have been detected with mental disorders, because we have electronic record. And in this electronic record, we have ICD-10 diagnosis, because the national system uses ICD-10, not DSM. The family doctors don't know. The psychiatrists do, but the family doctors know. And so we found out very interested in another study in another area. So 4 teams, 1 unit here and another unit with 3 covering the same area. In one, with the matrix support, with a family doctor, with a nurse with adequate training that had stability in that area, 8 years of work in that area, the detection was up to 50% of the expected prevalence. So 50% of those patients with alcohol problems were detected and treated. We did not go to analyze treatment yet. We are doing that. And we also got more around 2/3 of those with common mental disorders were detected. But in the same area, another unit with 3 teams where the doctor changes every year, the nurse changes, the manager changes, the doctors were not training adequately, the matrix supporter, psychologist, and psychiatrist changes, that disappears. Access disappears. In another unit, we were following on psychotropic medication, and one of our aims is one of our indicators is reducing the use of benzodiazepines and increasing adequate use of antidepressants and psychotropics such as neuroleptics. And that's what happened. So in another unit, in the middle of a slum with 2 teams, the level of benzodiazepines went down. And for our surprise, that was even better than we expected. Most of the medication that was taken by the patients was neuroleptic medication, which is the correct one, because it was a victory. I say it now, but 10 years ago, we did not have psychotropic medications in the primary care units because the mental health professionals did not agree. They would sit over the papers, and you know what happened? The patients went to justice, and the government changed it. And so when I don't know how you call health promoter or the person from justice that takes care of health issues in the city, when she called the new government, it was a family doctor, and he was crazy to change that. So when she asked why the doctors do not prescribe psychotropic medication in primary care, he said, like, yes, ma'am, we totally agree with you. We are doing that. And so now in Rio, not in the whole country, the medication, psychotropic medication, is being given, and there is a very strong movement to low down the use of benzodiazepine. So this is another intervention. The social support interventions, what we are doing are, until now, qualitative studies. And so we have been evaluating with using the SWOT, you know, SWOT? Yes. And most of for these group, handcraft groups, one of the results, I mean, sometimes it's so strange to consider their a success when it comes to quality of life. But those women were able to get out of the communities and go to other communities and participate in NGO action, participate in places and fair to sell the projects, the products and all that. It's unbelievable for me, you know, a PhD professor, to know a woman that will not get out of her community. But for them was a great increase in quality of life. Thank you for your question.
Thank you for your answer.
Sandra, could you speak for a minute about the relationship between the structure of the system that assigns every household within an area to the team, and how that might, getting to Iman's question, how that might enhance and support community-wide behavioral interventions, and if there's a relationship in terms of teams being responsible for whole households and communities,
yes,
and communities' responsiveness to those interventions.
One of our aims was, and we got it in the last government changed it 2 years ago, the new one is not so much committed to primary care, is that we managed to get what happens with other types of disorders. When you enter a unit, there will be a board, and in this board, how many families, how many people younger than 18, how many women, and they are all registered by the community workers. And this team is going to be sort of evaluated every year, based on those numbers. For instance, if you have 1,000 women between 18 and 60, you must have a certain number of preventive, Papa Nicolau and all these preventive actions done. If you have so and such a certain number of pregnant women, all these women must be under prenatal care visits and all that. And also, if you have tuberculosis, that's what Annika is working also. If a patient with tuberculosis is detected, during the first 2 months, the community worker will take the medication every morning. So, and to guarantee that he takes the medication in front of the worker. Dogs. Yes, we have dogs. One of the things we do is that we have invented, we are very good in inventing. People in Brazil are very creative. And so we have invented mental health dogs. And so, like I had a family with one patient that was the main care, most of the care of the house was done by a woman of 44 that that ended developing psychotic depression. And she had a schizophrenic son and a demented mother. And so, yeah, and so when we got to her, and guess who found her? The fact that she was psychotic, why diagnosed by the dentist? Because we have dentists, in every 14 have a dentist in Rio, but in this, it wasn't a trouble, another thing. The dentist called the doctor and said, look, she's psychotic because she came here 3 times because she says that she has verms, you say verms? And worms into her mouth. And I look, I examine, and there is nothing. And he said to the doctor, yes, the psychiatrist, and she has psychotic depression. But then we had a problem because they got all the medication mixed up. And so we had the community worker go there during 1 month, organize so that everybody takes its own, take the boy to the community mental health center, give the woman the adequate medication, and then the household sort of reorganize. I don't know if that answers your question. That also includes things like, do they have current water? Do they have adequate sanitation? And all this. They take care of, that's why we call intersectoral work. So in the interior of the country, one epidemic of problems with cattle was first detected by the family doctor, who noted that 3 or 4 of his patients that worked in cattle care and in cattle farms developed lesions in the hand. And so they contacted the public health unit for cattle care, and they came and there was an outbreak of one of these problems.
Thank you. We have time for one more question.
I think he has one.
Oh, sorry. We can make 2 more questions. Go ahead. Sorry.
Yes. So it's very interesting that there is some real structural difference, but I would say that there are more roadblocks here in the United States health systems compared to what you have described in Brazil. Does Brazil have a confidentiality sort of arrangement? Because in here we have the Health Information Portability and Accountability, or HIPAA Law Act, and that basically does not allow a doctor to speak to even another doctor unless it's with the patient's say-so, permission. But what you say is that there is this dynamic that allows for information to be readily shared among providers, and we do not seem to have that, strangely enough.
This is a good question. Now, once again, this is a good question. The different systems may have advantages. First of all, the primary care team has what is called sanitary responsibility, and that's over anything else. And so the community knows that they are responsible for it. Now, we don't have problems with the community workers getting to the house unless among the middle class and rich people. The poor, they like it very much for the teams and the community workers to go there. And so we have a special confidentiality organization between doctors. So you are under confidentiality issues whenever you get into a case. So if you get the case, the confidentiality aspects belong to everybody. Although some psychiatrists have now, in one city in the interior of Brazil, made exactly that question. We have confidentiality problems with the community workers. Then you have it, because they are not professionals. Yeah. And sometimes they are your neighbor. Or she is married to a man that had a fight with my husband. And you know how that goes on, so that can be a problem. We have problems of confidentiality with the community work. Not so much with the doctors, and also most of the consultations are done together. So the patient accepts that a psychology comes for the consultation with a nurse, that a psychiatry comes for the consultation. But there is another important issue. When it comes to ethics, it is in Brazil considered that if health is a right, not something you sell, what is it called?
Privilege.
Huh? No, not a privilege. A product,
commodity.
If health is not a commodity, the doctor cannot be sued because the result was not what the person expected on the basis that she did not get the product she bought for. He can only be sued if there was an error.
Malpractice.
So malpractice. You can be sued by malpractice. In private system, you can be sued because sued because you did not give the product they paid for, but not in the national health system. And so ethics committees and legal committees have already decided that when it is done in the national health system, you cannot be sued because you did not get the product you expect, because it's not a product. That person is employed by the system. It's not a person-to-person negotiation. And that helps a lot. That really helps it. One more? Yes.
Thank you very much for your presentation. I wonder if you could talk a little more about stigma. And I understand a big piece of destigmatizing is putting it in primary care as opposed to a standalone mental health system. But can you talk what else you do to reduce stigma and how effective that is, whether you think attitudes have changed in the 10 or 12 years you've been doing this?
Well, stigma is a problem. Stigma, the primary care, primary mental health care has helped a lot in reducing stigma for severe mental disorders, because the people are treated among everything. So they go to the dentist, they go to the nurse, and they take the medication, and they stay in the community. So this has seen a lot of improvement. What we did not have any success at all is alcohol and drugs. Still, there is a lot of stigma considering, and that's not a health problem. There is a problem of character, of you being weak, and all that stuff. And we have a big blockade for the community workers to enter that area. I was telling Jen this story that when we started talking about with the community workers how to deal with alcohol problems, one of them said, look, I can help, but not in my area, because she works in the area she lives. Because if I approach anybody who has an alcohol abuse problem, say, look, you may have a problem here, let's go to the doctor, let's see what we can do to help him, the answer would be, come on, I go to the bar with your husband. So nothing she can do. And so one important aspect was severe psychotic patients being kept in the community. And as it is my last question, I'm going to answer with a story. I love to tell stories, and we have several unbelievable stories, and I'm going to tell one to close answering your question. Because we talk a lot about using community, community help and community resources. And then one day there was this patient, this severely mentally ill patient, that she was controlled with long-term shots of alloperidol that were given, because this is another thing the primary care unit do. They keep an eye, because they provide medication, so they keep an eye. And the severe mental health patients, they come to the unit to get shots. I could go for a vaccine, somebody could go for an antibiotics, and they go for the shot. So that's how stigma decreases. It's just an everyday thing. But she was being treated in a community mental health center, but the shot was done, the medication was done in the primary care. And then one day she came and said to the team, I don't want to take this medication anymore. I'm fine. It's done. And they called the community mental health center, and the people in the community mental center were very hard. You have to give them the medication, because otherwise she's going to be crazy again, she's going to have another crisis, and if that happens, it's your responsibility. And they said, come on, how are we going to give it to her? She doesn't accept it. And the people, of course, typical mental health discourse, well, you hold her and give her the medication. And the people in primary care said, hold her? I mean, that's not something you do in primary care, no? But anyway, they tried. They came with the injection and the alcohol. And when the woman, it was in a very big slum, but a flat one. When the woman saw that, she had no doubt, she ran away. And their nurse technician had no doubt, she ran after her. And so there was in the middle of the community, the patient and the technician going after it. And the people from the narco-traffic dealers, which we call movement, that's one of the names they have, considered that was a very strange movement. And then When the patient came by them, they hold the patient and waited for the team. And when the teams arrived, they asked it because they call everybody doc, no? What's happening here, doc? And their nurse said, look, you know her, she has problems, she doesn't want to take the medication, and we didn't have anybody to hold her, to give the medication. And the guy turned to the nurse and said, oh, your problem is somebody to hold her. We are holding her. Get the medication. And she took the medication. And we consider this as an example of a community resource that has to be taken into consideration. Thank you very much.
Thank you once again, Dr. Fortes. I want to thank all of you very much. I want to thank Dr. Wisdom, the Center, and the staff at the Center for all the work you've done on Sandra's presentation and for throughout this semester. Dr. Almohandes for the invitation, certainly. And Sandra and I will be working most of the day tomorrow on the study and the IRB. But if there are folks who would like a conversation with Sandra, please email me, and we'll try our best to schedule something during the day tomorrow.
Wonderful. Thank you for joining us.
Thank you.